மேம் லைவ் போலாமா மேம்?
ஓகேடா, ஸ்டார்ட் பண்ணலாம்.
Very good evening to one and all who have joined here today. As a part two of our NEET PG Rapid revision series, we will be continuing our OBG revision session by Dr. Daffina Blessline, ma'am. Ma'am, over to you, ma'am.
Good evening. So let's continue with our session from yesterday. So let's start. First question is, a pregnant woman at 36 weeks of gestation with a prosthetic valve replacement for mitral stenosis is on warfarin therapy. Her INR is 3. What is the appropriate next step in management? Stop warfarin and start low molecular weight heparin. Stop warfarin and start heparin. Continue warfarin. Stop warfarin, start low molecular weight heparin and aspirin. Okay. So in this case, this patient is already on warfarin. Now she's reached 36 weeks of gestation. They are asking what is the next step. So before we go into that, we should know about the timings and how do we change the anticoagulation in pregnancy. Okay. So generally, compared to warfarin and heparin, which is the best drug, obviously warfarin is the best drug. Okay. But still, we don't give warfarin in the first trimester of pregnancy because it is associated with increased risk of congenital anomalies. We call that all skeletal anomalies. We call that as warfarin embryopathy. So it's better if we avoid warfarin in the first 13 weeks of pregnancy. Okay. Or at least up to 12 weeks of pregnancy. So if the patient was a known cardiac mother who was already on any anticoagulation like warfarin, once you know that she's pregnant, she has to stop the warfarin and she has to start low molecular weight heparin, which is enoxaparin clexane. Okay. She has to start clexane, which will continue till 12 weeks of gestation. So at 12 weeks, no longer she is at risk of congenital malformations. Now you can change it over to warfarin again. So she can be on warfarin now. So this changing over is not a instant process. Okay, you have to take time like 48 to 72 hours. She has to be on both warfarin and clexane, and then you have to keep increasing the dose, and you will monitor the INR and then come to a conclusion. That will be the target dose of warfarin, which she will continue till 36 weeks of gestation. So from 13 to 36 weeks, she can be on warfarin. Okay, at 36 weeks, again, you have to change it over to heparin. Warfarin is a more potent drug compared to heparin. So if the patient is on warfarin, the thing is at the time of delivery, there are increased chances of bleeding. So you don't want warfarin to continue at the time of delivery. So you're stopping warfarin at 36 weeks, and beyond 36 weeks, you start the patient again on low molecular weight heparin. So this should be stopped prior to delivery. How many hours prior to delivery? At least 6 hours prior to delivery, you have to stop this low molecular weight heparin or unfractionated heparin, whatever heparin she is on. Okay. So then after delivery, when do you resume? You can give 6 hours later in case of a normal vaginal delivery, or 24 hours later in case of a cesarean section, LSCS. So this is anticoagulation in pregnancy. First trimester of pregnancy, you start the patient on heparin. Till 12 weeks, she will be on heparin. Then you again restart her on warfarin. She has to continue warfarin till 36 weeks of gestation. At 36 weeks, again you will change her to heparin. And prior to delivery, 6 hours prior to delivery, you stop everything. Okay. And then after delivery, you can again restart. Either you can start on low molecular weight heparin, or if you want to straight away start with warfarin, you can start with warfarin also. After delivery, warfarin becomes safe. Okay. So sometimes there will be circumstances where the patient might come in spontaneous labor. So there would have been no chance you could have stopped this heparin. So what will you do? In that case, you can give the antidote, which is protamine sulfate, and then you can go ahead with delivery and then again restart heparin and warfarin after delivery. So this is regarding anticoagulation and pregnancy. The answer will be stop warfarin and start low molecular weight heparin. Okay. So what is this heparin then? Here, this is also heparin, this is also heparin. This plain heparin is unfractionated heparin. Okay, unfractionated heparin is not preferred. Why unfractionated heparin is not preferred? There are increased risk of complications. Second thing, for heparin to be unfractionated heparin, it will go as an infusion dose. So you don't have this once daily dosage. Whereas low molecular weight heparin is a very comfortable once daily dosage. Okay, so that's why we prefer low molecular weight heparin compared to unfractionated heparin. Okay, how do you monitor when the patient is on low molecular weight heparin? You do anti-10A levels weekly to monitor when the patient is on low molecular weight heparin. Okay, so this is regarding anticoagulation. Next thing, a 27-year-old female patient was found to have uterus didelphys. Which of the following is not likely to be a complication of this uterine anomaly? Okay, abortion, endometriosis, preterm labor, transverse lie. I hope all of you know the different congenital anomalies. Okay, uterine didelphys is where the fundus of the uterus is also indented. Okay, so there are two separate uterine cavities, two cervix. Okay, so this is a uterine didelphys. And other anomalies are arcuate uterus, where the portion near the fundus alone is indented. Otherwise, there's only a single uterine cavity. Then you have unicornuate, bicornuate, and septate uterus. Okay, so what are the complications of didelphys? One thing, because there is no proper uterine cavity, one thing that can lead to is preterm labor. Second thing it can lead to is abortion. Okay, miscarriages and abortions. That is one complication that can occur. Third thing is because there's a septum in between, because not a septum, because there is an indentation in the between, there is an increased chance of retrograde menstruation. So that retrograde menstruation can lead to endometriosis also. So an unlikely complication of uterine didelphys is transverse lie. Breech presentation is very common, but transverse lie will not occur in case of uterine didelphys. So one more question, frequently asked question when it comes to uterine anomalies is, they will give you a HSD picture. They will tell you to identify which is a septate uterus, which is a bicornuate uterus. Ideally, when you do a hysterosalpingogram, both will look similar. Okay, both septate uterus and bicornuate uterus is going to look similar. So how are you going to differentiate whether it is septate or bicornuate? That will depend on the intercornual angle. Okay, intercornual angle, if it is acute, if it is less than 75-degree intercornual angle, you call it as septate uterus. But if it's a very wide, obtuse intercornual angle, you call it as bicornuate uterus. So can you see this picture? Here it is a very acute angle. Here it's a very wide, obtuse intercornual angle. Okay, so that is how you can differentiate between a septate uterus and a bicornuate uterus. Okay. So this is another frequently asked question, but which is the gold standard investigation? Hysterosalpingogram you can do, but hysterosalpingogram will only tell you about the internal contour of the uterus. Okay, you don't know how it looks outside, because you look at septate uterus and you look at bicornuate uterus, only if you look at the outside of the uterus, you can diagnose. Right, in case of septate uterus, the external contour is normal, but in case of bicornuate uterus, the fundus is also indented. Okay, so to differentiate between that, you have to either do a laparoscopy, hysteroscopy along with a laparoscopy you can do, or one gold standard investigation is MRI. Okay, MRI is the gold standard for diagnosing any form of Mullerian anomalies. So this is regarding the congenital anomalies. One more question is, which is the most common Mullerian anomaly that can cause infertility? The most common Mullerian anomaly that causes infertility is septate uterus. Okay. Okay. Next, a woman who underwent dilatation and curettage for molar pregnancy 6 months ago presents with persistent symptoms of abdominal pain and distension. On further evaluation, the beta HCG levels were persistently elevated and Cannon-Ball foci were found on the chest X-ray. What is the appropriate management in this case? Given this history, what does it indicate? She underwent DNC for hydatiform mole 6 months back, but she continues to have the abdominal pain and distension, which means the molar pregnancy, not in the form of pregnancy, but that mole is persisting, and that in the persisting in the form of a gestational trophoblastic neoplasia. Okay, that is why the beta HCG levels are also persistently elevated, and it has also metastasized to the lung, causing Cannon-Ball foci. So what is the appropriate management? Okay, before we go into that, we should know how is gestational trophoblastic neoplasia managed. Okay, for the management of gestational trophoblastic neoplasia, you need to know two tables. One is the WHO prognostic scoring, the other is the FIGO staging. Okay, so what is this WHO prognostic scoring? So it takes into account all these factors. One is the age, the previous gestation, prior gestation, uh, the prior gestation which the patient had, the interval in months from the previous pregnancy, pre-treatment beta HCG, largest tumor size, site of metastasis, number of metastasis, and previously failed chemotherapy. Okay, depending on that, you have scores. When we can take into account this table, and if you look at the history that has been given to us, there's no age given to us. Okay, so we cannot comment about that. Second thing, antecedent gestation. We know that her previous pregnancy was a molar pregnancy. So that will be given a score of 0. Okay, antecedent gestation was a molar pregnancy. That is given a score of 0. Interval in months. Okay, compare from the prior pregnancy, what is the interval? It is 6 months. Okay, so 6 months. Where is it? Interval in months, 4 to 6. That is 1. Okay, any other information is given? Beta HCG levels were persistently elevated and cannonball foci were found. So what is cannonball foci? It is the metastasis in the lung. So you know the site of metastasis is the lung. So depending with the amount of data that we have, what is the WHO prognostic score? It is 1. Okay, apart from that, you need to know something. So when do you call it as low risk? Low risk is when the score is less than or equal to 6. High risk is when the score is more than or equal to 7. Okay, so now coming to the FIGO staging. FIGO staging, there are 4 stages. Stage 1 is when it is confined to the uterus alone. Stage 2 is when it is confined to the genital tract. Stage 3, when it has metastasized, when it has metastasized to the lung, with or without genital tract involvement. Okay, and stage 4. What is stage 4? Stage 4 when it has metastasized any other distant metastasis other than the lung, like liver. Okay, any form of distant metastasis. That is FIGO stage 4. Okay, so now depending on that, how do you give the treatment for gestational trophoblastic neoplasia? Treatment of gestational trophoblastic neoplasia. One, you take it as low risk. Who are the low risk GTN? Low risk GTN will be FIGO stage 1 to 3, provided your WHO prognostic score is less than 7. Okay, so in case of low risk females, what is your treatment? It is a single dose methotrexate. Okay, you give single dose of 50 milligram intramuscularly on days 1, 3, 5, 7 with folinic acid on alternate days. Okay, this is for low risk GTN. Low risk GTN will be FIGO stage 1 to 3 with a score less than 7. Single dose methotrexate is the treatment of choice. When it comes to high risk GTN, who are the high risk GTNs? Any FIGO stage 2 or 3, if the score is more than or equal to 7, or a FIGO stage 4, irrespective of the WHO score. Okay, any FIGO stage 2 or 3 with a WHO score more than or equal to 7, or a FIGO stage 4. In that case, high risk females, what is the treatment? It is a multi-dose chemotherapy. So what is the name of that regime? That regime is called EMACO regime. Okay, so what does E stand for? Etoposide, methotrexate, actinomycin D, cyclophosphamide. O stands for oncovin, which is your Win crystal. Okay, so low risk single dose methotrexate, high risk EMACO regime. Now coming to our question. So according to our question, what stage is it? It is FIGO stage 3 and WHO prognostic score of 1. So which means the woman comes under low risk GTN. So what is the treatment for low risk GTN? It is methotrexate with folinic acid. Okay. A female patient has a history of 3 miscarriages. Identify the investigation that was done from the image shown below. Okay. So she's had prior 3 miscarriages, high chance of congenital anomalies of the uterus. Okay. So what is the investigation done in this image? What is this investigation? It is a hysterosalpingography. Okay. So how do you identify if it's a hysterosalpingography? If you can see this cannula. What is the name of that cannula? It is Leach Wilkinson's cannula. What is the other cannula that is used? Rubin's insufflation cannula. Okay, these are the two cannulas which are used in hysterosalpingogram. Okay, it is an image-based question. So what is hysterosalpingogram? It is basically a imaging where you're going to insert a dye and look into the interior contour of the uterus. So when is it done? It is done from day 5 to day 10 in the pre-ovulatory phase. Pre-ovulatory phase, day 5 to day 10 you will do. So what are the uses of doing a hysterosalpingogram? One, you can do for the uterine anomalies, or if there is any synecdoche or polyps, anything in the interior of the uterus you can identify. Second use, to assess for the tubal factors of infertility. If you want to look if the tube is patent or not, you can use. Third use, you can assess if there is any cervical incompetence. Okay, these are the uses of hysterosalpingogram. What are the different contraindications of hysterosalpingogram? Okay. The contraindications of hysterosalpingogram will be any form of active bleeding or infection in the genital tract. Okay, any form of bleeding or infection in the genital tract. Pregnancy or suspected pregnancy is a contraindication. And premenstrual phase. You should not do hysterosalpingogram in the premenstrual phase. Okay, these are the different contraindications of a hysterosalpingogram. So use this contraindications, when is it done, and what are the two instruments that are used. Okay. A 56-year-old multipara woman presented with grade 2 bar 3 uterine prolapse with cystocele. She complains of passing urine on coughing and sneezing. What is the type of urinary incontinence seen in this patient? What are the two types of urinary incontinence that we know? Urinary incontinence is of two types. One is stress urinary incontinence. Second thing, urge urinary incontinence. Okay, so stress urinary incontinence is nothing. Whenever there is an increased intra-abdominal pressure, there's going to be leakage of urine. That is called as stress urinary incontinence. So what is the pathophysiology behind stress urinary incontinence? There is absence of detrusor muscle contraction. What is the pathology behind urge urinary incontinence? There is detrusor muscle hyperactivity or hyperreflexia. Okay, so stress and urge urinary incontinence. So stress urinary incontinence, you can see in cases of prolapse. Okay, it can occur in a wide range of conditions. Whenever there is an increase in the intra-abdominal pressure, it could be related to age, okay, menopause, because of decreased estrogen. All these can also contribute to the stress urinary incontinence. So, urge urinary incontinence, on the other hand, is very closely related to the neurogenic bladder. So, urge urinary incontinence is nothing but there is decrease in the capacity of the bladder and there is decreased urinary sensation. So, as a result of which, the patient will have the urge to void, but she will not able to control. She will not be able to control. Because of that, there is dribbling of urine. Okay, that's urge urinary incontinence. So this overflow incontinence and all was older term. Okay, it is a form of urge incontinence only. Because there is a decrease in the capacity of the bladder, as and when the bladder gets full, she is going to have dribbling of urine. Okay, on the other hand, when do you see neurogenic bladder? Neurogenic bladder is seen in conditions like Parkinson's disease, multiple sclerosis, any form of spinal injury. Okay, all these will cause neurogenic bladder. Okay. So now our question is, she's having a complaint of passing urine on coughing and sneezing. So what is that? Whenever there is an increase in intra-abdominal pressure, the answer is going to be stress urinary incontinence. Stress urinary incontinence, on the other hand, there are 3 grades. Okay, what is the 3 grades of stress urinary incontinence? Grade 1 is if there is dribbling of urine on severe stress. What is severe stress? Coughing, sneezing, all that will be severe stress. What is grade 2? Grade 2 is when there is moderate stress. Moderate stress in the form of either fast walking or climbing up and down of the stairs. Even in that case, if she's having dribbling, that is stage 2. What is stage 3? Stage 3 is when there is even when she is standing up. Okay, mild stress also is causing incontinence. These are the 3 stages of urinary incontinence. So our answer in this case will be stress urinary incontinence. A 30-year-old Gravida 4 abortion 3 had a history of miscarriage at 8 weeks, the second miscarriage at 11 weeks with no cardiac activity, and the third pregnancy loss at 24 weeks with preterm delivery due to early onset preeclampsia. What is the most probable diagnosis? Okay. So recurrent pregnancy loss. She has 3 abortions. Okay. What is the most common cause? It's very unlikely to be gestational diabetes mellitus. It can be syphilis. It can be torch infections, but they have classically given you one miscarriage at 8 weeks, one at 11 weeks with no cardiac activity, and one more she's had a pregnancy loss because of early onset preeclampsia. So all these going to point to the diagnosis of antiphospholipid antibody syndrome. So yesterday itself, we saw the criteria for antiphospholipid antibody syndrome. What is that criteria? You have lab criteria and you have obstetric criteria. What is the lab criteria? Lab criteria, I told you, the 4 antibodies that we discussed about. What are they? Anticardiolipin, lupus anticoagulant, and beta-2 glycoprotein, either IgM or IgG beta-2 glycoprotein. And what are the OBS criteria? OBS criteria, if she had 1 unexplained fetal loss, more than 10 weeks of gestation, 1 fetal death less than 34 weeks, either due to severe preeclampsia or eclampsia or any form of uteroplacental insufficiency, or if there were more than or equal to 3 first trimester abortions less than 10 weeks. Okay, so to diagnose APLA syndrome, you should have 1 OBS criteria and 1 lab criteria. Okay, in this case, they've not mentioned anything about the lab parameters, but given the history of 1 unexplained fetal loss, more than 10 weeks, 1 less than 34 weeks due to early onset preeclampsia, and 1 first trimester pregnancy loss less than 10 weeks gestation, most likely diagnosis will be antiphospholipid antibody syndrome. Another important cause of first trimester abortion is torch infections, but here everything is not first trimester abortions. You also had a uteroplacental insufficiency. So you should think of antiphospholipid antibody syndrome. The ultrasound of a young woman with infertility is suggestive of a uterine anomaly. Which of the following is used to confirm the diagnosis? The question is used to confirm the diagnosis. So what is it? Is it HSG? No. Why not HSG? HSG will not be able to look at the exterior of the uterus. You can only look into the internal contour of the uterus. So that is not the investigation of choice. Is it hysteroscopy plus laparoscopy? Yes. Hysteroscopy, you can look into the interior. Laparoscopy, you can look at the exterior. So as of now, that is a reasonable investigation. Is it laparoscopy alone? No. Laparoscopy alone is going to look at the external part only. So it's not laparoscopy also. Is it transvaginal sonography? Transvaginal sonography can be used as a screening to see if there is any uterine anomaly, but that cannot confirm the diagnosis. The most appropriate answer in this condition will be hysteroscopy plus laparoscopy. But if there was one more option that gave MRI, you should tell MRI as the answer. Okay, MRI is the gold standard investigation for the diagnosis of Mullerian anomalies. Okay, here there's no MRI in the option, so we'll go ahead with hysteroscopy and laparoscopy. It's very easy. You should look at both the interior of the uterus as well as the exterior of the uterus. So for that, you will need both hysteroscopy as well as laparoscopy. Okay. A 26-year-old pregnant woman on examination was found to have infraumbilical flattening. The fetal heart sounds were heard over the lateral side. What could be the fetal presentation or position? Okay. The classical terms in this question are infraumbilical flattening and fetal hearts heard over the lateral side, that is the flanks. That is classically seen in occipito posterior position. It's not seen in bro, which is another form of presentation. The head only is presenting, but it is in a extended state. So that is your bro presentation. Knee presentation is a form of breech only. Okay, because of the thighs will be extended, knees will be flexed. So that is why it is presenting as a knee. Okay, occipito posterior. Yes, occipito posterior is a condition where you're going to have infraumbilical flattening. And dorso anterior. Dorso anterior is nothing but your transverse line. Okay, so you can feel the head at one side, head in one flank, and the breech in the other flank. So it's not dorso-anterior also. So the answer is occipito-posterior. So occipito-posterior on per abdomen examination, what are the two things that you can find? One is subumbilical flattening, infraumbilical flattening, and FHR will be heard in the flanks. Okay. A preemie at term presented with labor pain and multiple painful vesicular lesions on her vulva. No rashes were found on other parts of the body. What will be the management of this case? Okay. Yesterday itself, we saw a table showing the different forms of genital ulcers. Okay. Of that, the classical description of a herpes ulcer will be multiple painful vesicles on a red erythematous base. Okay. That is how herpes simplex virus is going to present. Okay, herpes simplex virus 2, more than 1 is more prone for causing this herpetic ulcer. So what is the treatment for any form of herpes simplex infection? It's acyclovir. Okay, so that is clear. You have to give acyclovir. But is it cesarean section or is it induction of labor? This also we saw yesterday. When we saw that list of conditions for contraindications for induction of labor, we saw active genital herpes infection is a contraindication for induction of labor. So the answer will be acyclovir and elective cesarean section. Okay, next question. A 30-year-old married woman came for an infertility evaluation. On performing further investigations, intramural fibroids of sizes 7 into 5 centimeters and 5 into 3 centimeters were seen at the right and left cornual ends of the uterus. Her husband's semen analysis was found to be normal. What is the appropriate management of this case? Okay, so what is our case? So she's a 30-year-old married woman. She's on in evaluation for infertility. Okay, husband is perfectly normal. So the woman is having 2 large intramural fibroids that are sitting at the right and left cornual ends. Okay, so what is the appropriate management is the question. So any form of fibroid, if it is going to lead to infertility, the treatment will be myomectomy. Okay, you cannot be sitting and doing uterine artery embolization. Uterine artery embolization will again decrease the perfusion and increase the chance of infertility. So uterine artery embolization needn't be done. Artificial reproductive techniques. Okay, before we try artificial reproductive techniques, we can actually try removing the fibroid and seeing. Okay, sometimes if the fibroid is removed, there are chances she can conceive naturally also. So that is not the immediate treatment. GnRH analogs can be given. When do you give GnRH analogs? What is GnRH analog? Leuprolide. Okay, leuprolide, it is an intramuscular injection that you are going to give prior to surgery. Okay, if there is a woman who is waiting for surgery, if she's asked 6 months, if you are offering her surgery and then she's telling give me 6 months time, then in that 6 months you can give her this injection. Okay, that injection will actually reduce the size of the fibroid. That will help, that will ease your surgery. Okay, so prior to 3 months, if it's a very huge fibroid, you can give leuprolide injection and then take her up for surgery after 3 months because it will decrease the fibroid size as well as the vascularity rather than taking her straight away. Okay, but leuprolide alone cannot be the treatment because if you give leuprolide, the fibroid may regress. But again, after 6 months, it's going to regrow. So there's no point of giving leuprolide alone. Okay, it can be given preoperatively to reduce the size of the fibroid. So here, what is it? Appropriate management, infertility, fibroid treatment is myomectomy. A 28-year-old married woman who is anxious to conceive presents with copious vaginal discharge without any itching. Her last menstrual period was 13 days ago. What is the cause of her vaginal discharge? Candidiasis, bacterial vaginosis, trichomoniasis, and physiological. Okay, so before we go into that, I'll tell you which are the important catch points or one-liners that they'll give you in your question to identify the type of vaginitis that is occurring. Okay, so in case of candidiasis, classically, they'll tell you curdy white. Okay. And no itching. No similar complaints in partner. Okay. That is candidiasis. Candidiasis, they'll classically tell you curdy white discharge, non-prurite. Okay. In case of trichomoniasis, so trichomoniasis, you can have a yellow or greenish discharge. Okay. And on examination, you will have the strawberry cervix. Partner needs treatment. Yes, it is transmitted sexually also. So you have to treat the partner also. Okay. Next, what is the third thing? Bacterial vaginosis. What is the Amsel's criteria for the diagnosis of bacterial vaginosis? It will be a homogeneous vaginal discharge. Okay. Vaginal pH will be more than 4.5. On microscopic examination, you can see clue cells and you have something called as Whiff test, which is amine-like order on adding KOH to the discharge. Okay, which is Whiff test positive. Okay, amine-like order on adding KOH to the discharge. This is Amsel's criteria. Okay, this is for bacterial vaginosis. What is the fourth form of white discharge? It is your physiological white discharge. What is physiological white discharge called? Leukorrhea. What are the phases where you can get a physiological white discharge? Pregnancy, puberty, around ovulation. Okay, pregnancy, puberty, and around ovulation. Sometimes you can also get some in the premenstrual phase also. Okay, so of these, what is our question? Copious vaginal discharge without any itching. And they've classically given you last menstrual period was 13 days ago, which means what? Day 14 is the day of ovulation. So what is the vaginal discharge that occurs around the time of ovulation? It is the physiological white discharge, which is nothing but leukorrhea. Okay, this is how you have to answer any question that is related to white discharge. If you remember these points, depending on that only your answer will be made. If it's a curdy white discharge, it should be candidiasis. For trichomoniasis, they'll tell you yellowish or greenish discharge, which is strawberry cervix on examination. Bacterial vaginosis, it will more likely be a homogeneous vaginal discharge with clue cells, Whiff test positive, all that will be there. And physiological, they'll tell you around these times: pregnancy, puberty, or ovulation. Okay. A patient developed atonic postpartum hemorrhage after a normal vaginal delivery. She was shifted to the operation theatre and the obstetrician planned ligation of vessels to arrest the bleeding. What is the order of ligation of blood vessels supplying the uterus? Okay. What is the order of ligation? So before that, any form of PPH, initially you will try the medical management. What is the medical management? You can give oxytocin. You can give methogen. Methyl ergometrin can be given. Then you can give carboprost, which is PGF2 alpha. Okay. And then you can give PGF2 alpha. Carboprost can be given. Then you can give 800 micrograms of misoprostol per rectally. Okay, after all the medical management fails, tranexamic acid can also be given. After all the medical management fails, next thing that you will do is a surgical management. So what are the different forms of surgical management? One is sutures that can be taken. Okay, compressive sutures that can be taken. So what is that? B-Lynch suture or Cho suture. There are different types of sutures. The most prominent one is B-Lynch sutures. If it is not getting controlled even with the compressive sutures, what is the next step? You can go for the arterial stepwise devascularization. This is nothing but the stepwise devascularization. So you start with the uterine artery. Okay. After the uterine artery ligation, then you go to the ovarian artery. Even after ovarian artery, if it is not controlled, then you go to the internal iliac artery. Okay. Uterine artery, ovarian artery, and internal iliac artery. Okay. This is the order by order of doing stepwise devascularization. Okay. Even if after devascularization, even after ligation, if the bleeding is not controlled, what is the next step? If facilities are available, you can go ahead with the uterine artery embolization. But if there are no facilities, you will take the consent of the husband or the guardian, whoever is outside, and then you have to do a hysterectomy. Okay, there's no point waiting because there is no uterine artery embolization. Next step, you have to go ahead with the hysterectomy before she goes into frank DIC. Okay, this is how you will surgically manage the atonic BPH. The order of devascularization will be uterine artery, ovarian artery, and internal iliac artery. A teenage patient presented with a history of dysmenorrhea and chronic pelvic pain. On ultrasonography, a transvaginal septum was seen. What is the most common complication that can be seen in this patient? Endometriosis, tubo-ovarian abscess, dermoid cyst, theca lutein cyst. Okay. Yesterday itself we discussed cryptomenorrhea. There are two causes. What are the two causes of cryptomenorrhea? One is imperforate hymen. Second thing is a transverse vaginal septum. Okay. So transverse vaginal septum, how do they present? So they will have primary amenorrhea. Along with that, they will have cyclical abdominal pain. Okay. Cyclical abdominal pain. When you do a local examination, you can see a transverse membrane that is covering the vagina. Okay. So the transverse membrane covering the vagina. You cannot see a bluish bulge that you will see in the imperforate hymen. But here you can see a mucous membrane that is covering the vagina. Okay. So in that case, transvaginal septum has to be resected locally. Okay, that will be the treatment for transverse vaginal septum. But what are the complications that can occur because of transverse vaginal septum? The most important complication is an endometriosis. Why endometriosis? Because there is a retrograde menstruation. Okay, there are many theories for endometriosis, out of which an important theory is retrograde menstruation. So there is a backward flow of the menstrual blood. It's not able to come outside because there's a septum. So it's going to flow backward. And as you all know, implantation of the endometrium at sites outside the uterus can lead to what is called as endometriosis. So that is the reason for endometriosis. The most common complication that is seen with the transverse vaginal septum out of these options is endometriosis. Very unlikely for it to cause a tubo-ovarian abscess. That is the most common complication of a pelvic inflammatory disease. Dermoid cyst, it's unlikely. Theca lutein cyst and all will occur when it is a gestational trophoblastic disease. There is no history suggesting of this gestational trophoblastic disease. So the answer will be endometriosis. They have also given you the history. Even if you don't know all this, they have given you dysmenorrhea and chronic pelvic pain, which is classically seen in endometriosis. Okay. A 28-year-old pregnant woman came for a routine antenatal checkup in her second trimester. 4 years back, she delivered 2 healthy full-term twins. What would be her obstetric score? Okay. So, 4 years back, she has delivered twins. This is the second time she has become pregnant. Okay, you all know what is gravida. You know what all know what is para. All know what is live. I hope. Okay. Gravida is nothing but the number of times the patient has conceived. Para is nothing but the number of times the pregnancy of the patient has crossed the period of viability. Live is the total number of live children that were born each time. Okay. So when it comes to gravida, she was already pregnant once 4 years back. Now she's pregnant for the second time. So that will be G2. What is para? Because she delivered twins, it doesn't mean your para will be 2. Okay, para you will not include the current pregnancy. Para is the outcome of the previous pregnancy. Okay, both gravida and para, you're going to take account the pregnancy only, not the number of times she has delivered. Okay, you're going to take into account the pregnancy. So this is the second time she's becoming pregnant, so it's gravida too. Whereas para is nothing. 4 years back, she has delivered twins. Even though there were two babies that were delivered, that is a single pregnancy that has crossed the period of viability. It is a twin pregnancy. So para will be 1. Okay, para will not increase based on the number of gestation. Okay, if it's a twin pregnancy or if it's a triplet, if it's a quadruplet, para will remain 1. Okay, it only corresponds to the pregnancy. It does not correspond to the number of babies. Okay, live is the number of live children. Here they have not asked about the live status. Okay, so the answer will be G2P1. A 27-year-old woman who's on oral contraceptive pills for contraception has forgotten to take her pills on 4 different days in the last 2 weeks. She presents to the primary health center asking for advice. What would you suggest to her? If she's missed 1 pill, 2 pill, 3 pill, you have the confusion. But she's already missed 4 pills. So what will be the answer? Discard the pack, start a new pack. Till then, you have to continue with an alternate method of contraception, like a barrier method for 7 days. Okay. So that is the answer. So there is one table. This is the table that was previously followed. So if the woman had missed 1 pill, then you will take the missed pill alone as soon as possible and you will resume the rest of the schedule as per the pack. Okay, you need not use any backup method for that. If she's missed 2 pills, in first or second week, if she has missed 2 pills, she has to take 2 pills every day. Okay, for 2 days, and then she has to continue the remaining of the schedule and finish the pack. Okay, backup is actually not needed, but as a general practice, we advise for 7 days. Okay, backup is nothing but using a barrier method or any other form of alternate contraception. Okay, then if she has missed 2 pills in the 3rd week, then she has to abandon the entire thing. She has to start a new pack and use a backup method for 7 days. Okay, similar is the thing when she has missed more than or equal to 3 pills. Then she has to start a new pack and use a backup method for 7 days. Okay, the recent Government of India guidelines has changed. Okay, if she has missed 1 or 2 pills, she has to take either 1 or 2 pills, how much ever she has missed, as soon as possible and resume the rest of the schedule. There is no backup method that is needed. But if she has missed more than or equal to 3 pills in the first or second week, then she has to take 1 hormonal pill as soon as possible and continue the remaining schedule as per the pack and use a backup method for 7 days. Okay, this is if it is in the first or second week if she has missed more than or equal to 3 pills. 1 pill she has to take as soon as possible, continue the rest of the pack and use a backup method for 7 days. But if she has missed more than or equal to 3 pills in the 3rd week, okay, then as soon as possible she has to take 1 hormonal pill and finish all hormonal pills in the pack as scheduled. Okay, so as you all know, the 28-day pack, there will be 21 hormonal pills and 7 non-hormonal pills. So if she has missed more than or equal to 3 pills in the 3rd week, okay, she has to take 1 pack and finish all hormonal packs. She has to discard the non-hormonal pills and take a new pack. Generally, what do we tell? Starting from day 1, they will take one hormonal pill. Last 7 days, that is the 4th week, they will take only the non-hormonal pill. But in this case, you will tell them to discard the non-hormonal pill and start the next hormonal pack on the 4th week. Okay, this is the recent guideline. Okay, so according to that, our question, what have they asked? She has already missed 4 pills. So if she has missed 4 pills, the answer will be to discard the pack and to start a new pack with an alternate method of contraception. A 30-year-old female patient on treatment for infertility came with 6 weeks of amenorrhea, abdominal pain, and mild vaginal bleeding. Her beta HCG level was 2800. On ultrasound, a 3 centimeter mass was seen in the left adnexa. It contained a gestational sac with no fetal cardiac activity. What is the most appropriate management for this patient? So, what is the diagnosis? What have they given? She's having amenorrhea, abdominal pain, and vaginal bleeding. Okay, so she's also having a increased beta HCG level to 2800. They've done a scan. In the scan, they can see a 3 centimeter heterogeneous mass sitting in the left adnexa with no fetal cardiac activity. Only an empty gestational sac is present. So what is the diagnosis? It is a left unruptured tubal ectopic. Okay, left unruptured tubal ectopic. So what is the appropriate management for this patient? Okay, for that we should know how do we manage an ectopic pregnancy. Okay, one is the expectant management. Second thing is the medical management. And third thing is the surgical management. Okay. Expected management. What is the expected management? You're not going to do anything. You're going to conservatively manage. You're going to serially follow her up with beta HCG. That is expected management. So when do you do expected management? The patient should be perfectly hemodynamically stable. Okay. With a beta HCG level that is less than 1500. In that case, you can repeat the beta HCG after 48 hours. And you have to see the trend of beta HCG, if it is increasing or decreasing. Depending on that, if it is decreasing, you can serially monitor the beta HCG till it comes to a lower value. Okay, that is the expectant management. What is medical management? Medical management, what is the drug that we are going to use for ectopic pregnancy? Methotrexate. Either single dose methotrexate or multi-dose methotrexate can be used. So when do you give medical management? For medical management, the criteria is patient should be hemodynamically stable. Okay, the gestational sac size should be less than or equal to 3.5 centimeter. There should be no cardiac activity. Okay, and beta HCG level should be between 1500 to 5000. Okay, in these cases, you can do a medical management with methotrexate. So how do you give methotrexate? Either single dose methotrexate. Single dose methotrexate is given as 50 milligram per meter square. Okay. Then multi-dose methotrexate is given as 1 milligram per kg on days 1, 3, 5 and 7 with folinic acid on alternate days. Okay, this is single dose methotrexate, multi-dose methotrexate. Who do you give? Hemodynamically stable patient. Sac size is less than or equal to 3.5 centimeter. No cardiac activity. Beta HCG is between 1500 to 5000. Surgical management, whatever is exactly opposite to this. Okay. So surgical management, you can either do a salpingectomy or a salpingostomy. Previously, they were doing milking of the tube and all. That is not done nowadays. Okay, either a salpingectomy or a salpingostomy can be done. Salpingectomy is where the tube is entirely removed. Okay, salpingostomy is where a hole is made in that particular part of the fallopian tube and the ectopic gestation is removed. Okay, that is a surgical management. So when do you do surgical management for ectopic pregnancy? Patient is hemodynamically unstable. You're getting a patient in the casualty, okay, in your resuscitation room with the hypotension, with tachycardia, with severe pain, okay, with hemoperitoneum. All these will be indications that the ectopic pregnancy has ruptured. So anytime if it's a ruptured ectopic pregnancy, it is an emergency. You cannot be giving methotrexate in that case. So if it's a hemodynamically unstable patient with severe pain or hemoperitoneum. Next thing, beta HCG is more than or equal to 5000. Your sac size is more than or equal to 3.5 centimeter with cardiac activity. Okay. Anytime if there is a fetus with cardiac activity, it's more prone for rupture. So you cannot be waiting. In that case also you have to do a surgical management irrespective of the size of the gestational sac. Okay. These are the different ways by which we manage ectopic pregnancy. So what is our question? So what did she have? She had amenorrhea, abdominal pain, mild vaginal bleeding only. Beta HCG was 2800. Okay. Sac size was 3 centimeter. Did it have cardiac activity? It had no cardiac activity. So all these criteria are fitting into what? Medical management. So what is medical management that we are going to give? We are going to give single dose of methotrexate. Okay. Single dose methotrexate will be the management for this patient. A 30-year-old woman on oral contraceptives for the past 6 months presents with 6 weeks of amenorrhea. What would be the best method of assessing the gestational age of this patient? Okay, best method of assessing gestational age. In case of first trimester, it is the crown rump length. In case of second trimester as well as the third trimester, you can take into account all the parameters of fetal biometry, which includes biparietal diameter, abdominal circumference, head circumference, femur length. Okay. For first trimester, it is the crown rump length. So how do you calculate the gestational age depending on the crown rump length? Crown rump length plus 6.5 will be gestational age in weeks. Crown rump length plus 42 days will be gestational age in days. Okay, this is a formula for calculating the gestational age depending on the crown rump length. Crown rump length plus 6.5 will be gestational age in weeks. Crown rump length plus 42 days will be gestational age in days. So what is the answer for this? Patient is in her first trimester. What was the period of amenorrhea? 6 weeks of amenorrhea. So what will be the best method? Crown rump length by ultrasound. Okay. A pregnant lady with 34 weeks of amenorrhea has the following findings. LDH of 700, platelet of 75,000, serum bilirubin of 1.5 milligrams per deciliter, SGOT of 200, SGPT of 150, and her blood pressure is 140/96. Her coagulation profile and renal function tests are normal. What is the diagnosis? HELP syndrome, acute fatty liver of pregnancy, viral hepatitis, intrahepatic cholestasis. We had already seen this topic yesterday. So what is the diagnosis? She's having what is HELP syndrome? Hemolysis, elevated liver enzymes, low platelet count. Is she having hemolysis? Yes, her serum bilirubin is elevated, which means there is some hemolysis going on. So H is fulfilled. Is she having elevated liver enzymes? Yes. SGOT, SGPT, LDH is elevated. So elevated liver enzymes is also there. Is she having low platelet count? Platelet is only 75,000. So that is also satisfied. So along with that, she's also having increased BP. So yesterday when we saw the table, we saw how do we differentiate? In case of HELP syndrome, she's going to have hypertension associated to that. Okay, they did not give you any features of pruritus. She did not give you liver failure. They did not tell you about any infection fever. So the diagnosis here points towards HELP syndrome. What is the criteria that we use for the diagnosis of HELP syndrome? It is called Tennessee criteria. Okay, Tennessee criteria is nothing but platelet count less than 1 lakh, SGOT, SGPT more than 70, LDH more than 600, and there should be some form of hemolysis. Okay, hemolysis either in the form of increased bilirubin or abnormal peripheral smear. So this is the criteria for the diagnosis of HELP syndrome. So what is this? What is the answer in this condition? It is HELP syndrome. This is a very important table that will help in the arriving at the answer for all these liver disorder questions. A woman at 26 weeks of gestation presents for routine evaluation. On examination, fundal height corresponds to 24 weeks. At 26 weeks, it's corresponding to only 24 weeks. Ultrasonography revealed decreased amniotic fluid. So which of the following conditions would have led to the presentation? So what is the answer? Either renal agenesis, tracheoesophageal fistula, cardiac abnormalities, urethral stricture. So the answer will be, first of all, what is the diagnosis? The fundal height is less when compared to the period of gestation and there is decreased amniotic fluid. So the diagnosis will be oligohydramnios. When do you diagnose oligohydramnios? If the single Leica pocket is less than 2 cm or the amniotic fluid index is less than 5 cm. Okay, so as we all know, more than 20 weeks of gestation, what is the most important contributor for amniotic fluid? It is fetal urine. But if the baby is having renal agenesis, it's not going to produce adequate urine. So that is the reason for oligohydramnios. Okay, on the other hand, tracheoesophageal fistula and cardiac abnormalities will lead to polyhydramnios. Urethral stricture has no role in that. If it's a posterior urethral valve or an obstructive uropathy, that can lead to oligohydramnios. Urethral stricture will not lead to oligohydramnios. Okay, renal agenesis will be the appropriate answer. The definition of oligohydramnios is an amniotic fluid index of less than 5 cm or a single Leica pocket less than 2 cm. Okay. Similarly, what is polyhydramnios? Polyhydramnios is when the AFI is more than 25 cm or the single Leica pocket is more than 8 cm. Okay, so this is a table that is showing the different causes of oligo and polyhydramnios. What can be the causes of oligohydramnios? You can divide it as maternal, fetal and placental causes. What are the maternal causes? If there is any undiagnosed rupture of membrane. So the mother might have leaked before without her knowing itself. So that is one cause. Second thing, spontaneous rupture of membrane. So this undiagnosed rupture of membranes is the most common cause of oligohydramnios. Next thing, she might have had spontaneous rupture of membrane. Any post-dated pregnancy, preeclampsia, use of NSAIDs or AC inhibitors can cause oligohydramnios. What are the fetal causes? fetal anomalies, either renal agenesis or any urethral defects, as I already told you, either in the form of a posterior urethral valve or an obstructive uropathy. Okay, what are the placental causes? There is one rare cause, rare disorder of the placenta, right? The placenta fails to secrete amniotic fluid. So what is that called? Amnion nodosum. Okay. So what are the causes of polyhydramnios? Polyhydramnios, we all know the most common cause of polyhydramnios is not diabetes mellitus, it is idiopathic. Okay, if they ask you a question, what is the most common cause of polyhydramnios? It is idiopathic. The second cause only will be uncontrolled diabetes mellitus. So either overt diabetes or gestational diabetes or any form of cardiac, renal or liver disease in the mother can lead to polyhydramnios. What are the fetal disorders that lead to polyhydramnios? Multiple gestation, neural tube defect, abdominal wall defects, cleft palate, any form of neck mass, esophageal atresia, tracheoesophageal fistula, aneuploidy, hydrops fetalis, and twin-to-twin transfusion syndrome. All these are different anomalies that can lead to polyhydramnios. Of these, most important will be neural tube defect, esophageal atresia, and tracheoesophageal fistula. Okay, what is placental cause of polyhydramnios? You have a condition, a benign tumor called chorangioma of the placenta. So that can lead to polyhydramnios. These are the different causes. So the same question has also been repeated once again in a different form. So here they had asked you about oligohydramnios. Same thing they will ask about polyhydramnios. Okay. Polyhydramnios, how will they give the scenario? Large for gestational age. So the fundal height will be more when compared to the gestational age. Okay. And second thing that they will have is you can fundal height will be more, and second thing, amniotic fluid analysis will show AFI of more than 25 centimeter and a single LICA pocket of more than 8 centimeter. Very rarely towards term, already the mother will have increasing discomfort, but because of the increased amniotic fluid, she can have exertional breathlessness. So that is one more way they can show, they can put out a question for polyhydramnios. Okay. A type 1 diabetic mother is on magnesium sulfate infusion post-cesarean section for preeclampsia. She develops delirium and is drowsy. She has a respiratory rate of 10 per minute and random blood glucose level of 240 milligrams per deciliter with oliguria and bilaterally absent knee reflex. What is the cause of her condition? Bilaterally absent knee reflex, mother who is on magnesium sulfate, what will be the answer? It is magnesium sulfate toxicity. Why did they give you this type 1 diabetes, blood glucose level of 240 and all that? To confuse you if it is diabetic ketoacidosis. What is the level of blood sugar at which diabetic ketoacidosis will occur? At least you should have a random blood sugar of 380 for DKA to occur. Okay, so it can rarely occur below that also, but given this clinical scenario with decreased respiratory rate, oliguria, bilaterally absent knee reflex with delirium, all these will point to the diagnosis of magnesium sulfate toxicity. Okay, so what is the why do we use magnesium sulfate? Magnesium sulfate is either used to control seizures in case of recurrent eclampsia or to prevent seizures in case of severe preeclampsia. You're going to give magnesium sulfate. What is the other use of giving magnesium sulfate? You can give it as a tocolytic, okay, as a uterine relaxant. What is the third use? You can give it for neuroprotection to prevent cerebral palsy in case of preterm infants. You can give magnesium sulfate. These are the three different uses. What is therapeutic level of magnesium sulfate? It is 4 to 7 milliequivalents per liter. When do you suspect magnesium sulfate toxicity? There are certain signs of magnesium sulfate toxicity which I will be coming. But before that, whenever you get a serum creatinine that is more than 1 milligram per deciliter, you have to monitor the serum magnesium levels also. Okay, so how does magnesium sulfate toxicity present? So they can have chest pain, heart block, visual changes, dizziness, facial flushing. Okay, respiratory rate less than 12 per minute. Urine output less than 30 ml per hour. Absent deep tendon reflexes. Okay, these are the ways by which magnesium sulfate toxicity is going to present. Whenever you diagnose magnesium sulfate toxicity, what do? You immediately stop the magnesium sulfate. Okay, stop the magnesium sulfate. What is the antidote that you're going to give? You will give IV calcium gluconate. So how much will you give? 10 ml of 10% calcium gluconate, slow IV over 10 minutes. Okay, 10, 10, 10. 10 ml of 10% slow IV calcium gluconate over 10 minutes. That's how you are going to give. Okay, one more thing. What are the two different regimens that you will use, that will be asked when they ask about magnesium sulfate? One is Pritchard regime. The other is Pritchard regime. The other is Zuspann's regime. Okay, Pritchard and Zuspann. Each will have a loading dose and a maintenance dose. Loading dose is similar in both the cases. Okay, you will give 4 gram of 20% magnesium sulfate. Okay, over 20 minutes IV. Okay, that will be the loading dose in both the cases. For maintenance dose, how will you give Pritchard's regime maintenance dose? You will give 10 gram of magnesium sulfate, 5 gram in alternate buttock. Along with that, you will give 5 gram after that every 4 hours once in alternate buttock. Okay, so total 10 gram of magnesium sulfate you are going to give us 5 gram and 5 gram in each buttock. Then after that, every 4 hours once you are going to give 5 gram. Okay, that should be at least till 24 hours after the last seizure or delivery, whichever is happening later. Okay, initial loading dose is going to be same. Loading dose, you will give 4 gram of 20% magnesium sulfate IV over 20 minutes. Okay, then in case of Pritchard's regime, it's an IM regime, intramuscular regime. Okay, so you're going to take 10 gram of magnesium sulfate. In each buttock, you will give 5 and 5 gram. After that, every 4 hours once, you will give 5 gram in alternate buttock. Okay, till 24 hours after delivery or seizure, whichever is happening later. Okay, so that is Pritchard's regime. For Zuspann's regime, it's very simple. You will give 1 to 2 milligram per hour. Okay, at least for 24 hours after delivery, you will give as IV. Zuspann is IV. Okay, these are the two different regimes that are used for giving magnesium sulfate. Identify the type of hymen shown in the image. This hymen with a transverse septum in the middle. What is this? This is a septate hymen. Okay, so this is a very important image based question where they will give you the different images of the different types of hymen and they will ask you to identify. Okay, so this is an annular hymen, crescentic hymen, septate hymen. If there are multiple dots, that can be a cribriform hymen. This is an imperforate hymen where you cannot see any opening. Microperforate hymen is a small opening in the hymen. Labial and denticular hymen, fimbriated hymen. Okay, these are the different types of hymens. While discharging a patient who underwent a vesicovaginal fistula repair, which of the following would you recommend? Sexual abstinence for 3 months and avoid pregnancy for a year. Sexual abstinence for 3 weeks and avoid pregnancy for 6 months. Sexual abstinence for 6 weeks and avoid pregnancy for a year. Sexual abstinence for 6 months and avoid pregnancy for 6 years. So we give sexual abstinence for 3 months and avoid pregnancy at least for a year. So what is vesicovaginal fistula? Vesicovaginal fistula is a frequent complication that happens with obstetric trauma at the time of delivery. So once you repair the vesicovaginal fistula, you should avoid any perspeculum or pervaginal examination or any sexual intercourse for 3 months following the repair, and they should ideally avoid pregnancy for at least a year. Okay, even after a year, if they are going to become pregnant, you will not allow for normal vaginal delivery. You will do a lower segment cesarean section, LSCS. This previous vesicovaginal fistula repair is one of the contraindications for induction of labor. So next pregnancy will be a LSCS. Which of the following is an absolute contraindication for the insertion of the device shown in the image below? So what is this? This is copper T. Okay. What type of copper T? So we'll come to that. I'll show you the images. So what is the complication? Is menstruation contraindication? Is menstruation a contraindication for copper T? No. Is trophoblastic disease a contraindication? Yes. When there is a gestational trophoblastic disorder going on, you will not insert a copper T. Can you insert immediately after delivery? Yes. Can you insert in case of a ruptured condom during intercourse? Yes. So that is where it is called as emergency contraception. Okay. So that contraindication will be trophoblastic disease. So these are the different contraindications of intrauterine contraceptive devices. Trophoblastic disease, distorted uterine cavity, if there is any ongoing pelvic infection or bleeding, if there is any form of suspected pregnancy, severe dysmenorrhea, any sexually transmitted infection, Wilson's disease, and copper allergy, and breast cancer. All these will be the contraindications of IUCD. What are the different timings of insertion of copper T? One is interval. Okay, interval will be 2 to 3 days after menstruation. That is called interval insertion. Next thing is post-placental insertion, which will be immediately after delivery of the placenta. Okay, next is postpartum. So this can be after delivery up to 6 weeks postpartum. You can insert the copper T. Okay, last thing is the emergency contraception. So within 5 days of an unprotected sexual intercourse, the copper T is inserted. Okay, so these are the different timings of insertion. So these are the different types. So the image that was shown to us was copper T 200. Okay, this is a copper T 380A. So the load alone will differ in that. Okay, then this is Nova T. This is another image based question. This is your multi-load copper T. Okay, multi-load copper T. This is your Mirena, levonorgestrel IUS. Okay, these are the different image-based questions that they can ask. A pregnant woman with no other comorbid conditions develops preeclampsia. She inquires about the cause of her condition. The doctor explains that it is due to failure of the invasion of spiral artery by villus trophoblasts, radial artery by cytotrophoblasts, spiral artery by extravillus trophoblasts, or arcuate artery by extravillus trophoblasts. What is the answer? This is a straightforward question. What is the pathophysiology behind preeclampsia? Spiral artery by extravillus trophoblasts. What is the timing for termination of pregnancy for preeclampsia? Yesterday we had discussed. It is 37 weeks. Okay. So the pathophysiology behind that is spiral artery. So generally in pregnancy at around 20 weeks, your low resistance spiral arteries should, your low volume spiral arteries should change into low resistance, high caliber spiral arteries. So for that to happen, what should happen? Trophoblastic invasion, extravillus trophoblastic invasion should happen. Okay, only if that happens, the small spiral arteries will change into large spiral arteries which are with a low resistance. But what is the need for it to become a low resistance large spiral artery? So that your blood flow will increase. Okay, your uteroplacental blood flow has to increase. So that is why your spiral artery has to change into large caliber spiral artery. So that is brought about by what? By the trophoblastic invasion, extravillus trophoblastic invasion. Okay. Other mechanisms that can lead to are, as you already know, angiogenic, anti-angiogenic imbalance. And there can be also an endothelial dysfunction that is brought about by interleukins, prostaglandins, cytokines. All these can bring about a endothelial dysfunction. This is about the pathophysiology of preeclampsia. The most important thing will be failure of invasion of spiral artery by the extravillus trophoblast. Okay. A woman with an obstetric score of G2P1 comes to the clinic at 14 weeks of gestation for her routine antenatal checkup. A uterine artery Doppler was suggested by the doctor. What would it detect? At 14 weeks of gestation, if you do a uterine artery Doppler, that is used for the screening of what? Early onset preeclampsia, late onset preeclampsia, fetal growth restriction, or placenta accreta. It is early onset preeclampsia. Okay, it is one of the marker for early onset preeclampsia. So how do you detect early onset preeclampsia? One is on uterine artery Doppler. You can get a diastolic notch and high resistance flow. Okay, and then what is the other thing that you can get that suggests the early onset preeclampsia? Apart from the uterine artery Doppler, there can be umbilical artery Doppler changes also. There can be increase in the end diastolic frequencies. So umbilical artery Dopplers will also help in diagnosing early onset preeclampsia. Then any mean arterial pressure that is more than or equal to 90 millimeters of mercury in the second trimester. That will also predict early onset preeclampsia. Last thing is the rollover test. Okay, all these will help in detecting the early onset preeclampsia. While conducting a delivery, you perform the maneuver shown below. Following this, there is incomplete separation of placenta and massive hemorrhage. What is your next step in management? start oxytocin infusion and wait for spontaneous delivery of placenta, uterine massage, arrange blood and use Creed's method for placental delivery, and manual removal of placenta. So what is the answer? What are they doing? This picture is showing what? It is showing active management of third stage of labor, which is called as the Brandt-Andrews maneuver. So what are they doing? One hand is giving suprapubic pressure. The other hand is removing the placenta by controlled contraction. Okay, it is a step in the active management of third stage of labor. So even after doing this, the placenta is incompletely separated. There is some retained placenta inside that is causing the atonic BPH. What will you do? You can no longer wait. Now she's already bleeding. So you cannot start oxytocin infusion unless the placenta is completely out. Okay, before the placenta, this is an important thing that has to be remembered practically also. So before the placenta comes completely out, you should never start the oxytocin infusion. As we all know, in active management of third stage of labor, there are 3 steps. What are the 3 different steps? One is to give intramuscular 10 units intramuscular oxytocin immediately after the delivery of the shoulder. Second thing will be controlled contraction and delivery of the placenta. Third thing will be uterine massage. Uterine massage is now not a part of active management of third stage of labor. Only 2 steps are there. Okay, so now when we are, even after removing the placenta, if the uterus, if there is some retained bit inside that is causing the bleeding, you should never start the IV oxytocin infusion. Okay, that will lead to contraction of the uterus and that retained placenta will not come out. Okay, so to avoid that, what will you do? Immediately after delivery of the placenta, if you feel if it's still bleeding, you will do a pervaginal examination and attempt a manual removal of the placenta. Okay, so the next step in management will be a manual removal of the placenta. This can be either done in the labor room setting, or if the patient is acutely bleeding, if she's having severe hemorrhage and all, it's better if you can take her to a theater setting under anesthesia if the manual removal is done. Okay. So when you do a manual removal of placenta, one more recommendation is you should give prophylactic antibiotics. Okay, 1 dose of ampicillin, 1 dose of metronidazole is to be given immediately after manual removal of placenta is done. Okay. So this is the Brandt-Andrews maneuver or controlled contraction. But they have mentioned something called as Creed's method. Creed's method is a method that was invented in 1853. It's a very way old method which we are not following now because it increases the chance of uterine inversion. So what is the Creed method? With one hand, the uterus is held, per abdomen uterus is held and it is squeezed and then the placenta is removed with the other hand. Okay, can you see the other hand is doing a pervaginal examination and removing the placenta. This is not done nowadays. Okay. 2 other named methods of placental separation. One is the Scult's method. What is Scult's method of placental separation? When it is separating from the center. Okay, central placental separation is called as Scult's method. What is done? Matthew Duncan's method. Matthew Duncan, M stands for M. So marginal separation of the placenta is called as Matthew Duncan's method. Okay. A female patient collapses soon after delivery. There is profuse bleeding and features of disseminated intravascular coagulation. Which of the following is the most likely etiology? So the answer is amniotic fluid embolism, postpartum hemorrhage, peripartum cardiomyopathy, or rupture of the uterus. It is definitely not. It can be postpartum hemorrhage, but the thing is she has collapsed and there is profuse bleeding. Features of DIC are there. Okay, postpartum hemorrhage, to go into DIC, she should have bled a lot. But there is no history suggesting about very excessive hemorrhage or something. Okay, so postpartum hemorrhage can be ruled out. There is no history suggestive of any heart failure. So peripartum cardiomyopathy can be ruled out. Rupture of uterus, how does it present? Hypotension, okay, tachycardia. There is no feature suggesting rupture of the uterus also. So the answer will be amniotic fluid embolism. So what is the diagnostic criteria of amniotic embolism? Amniotic fluid embolism. So it's a triad. Okay, there should be respiratory compromise, cardiovascular compromise, and DIC. Okay, all these will form part of the triad of amniotic fluid embolism. Okay, amniotic fluid embolism, when does it occur? It actually occurs either in the at the time of labor or within 30 minutes after delivery of the placenta. That is a time when amniotic fluid embolism can occur. So here, disseminated intravascular coagulation is the key word that is pointing towards amniotic fluid embolism. You are examining a multigravida in the second stage of labor for the past 2 hours. On examination, the contractions are adequate. The cervix is dilated with the head at station 0, with molding at 2+ and caput at 2+. The sagittal suture is in the right occipito transverse position. The fetal heart rate is 140 per minute. Which of the following is carried out for the management of this patient? So what are they saying? Patient is already in the prolonged second stage of labor. When do you call as prolonged second stage of labor? After full dilatation for primigravida, if it is more than 2 hours. For multigravida, if it is more than 1 hour. Okay. But for her, already multigravida, second stage of labor for the past 2 hours. Okay. She is having adequate uterine contractions. Cervix is fully dilated, but the head is persistently at station 0 with caput and molding. Okay. The important keyword that is given is the sagittal suture is in the right occipito-transverse position. Usually it is in the either the left occipito-anterior or the right occipito-anterior position. Okay. So that will aid in the normal vaginal delivery. But what has happened here? So it must have been a occipito-posterior that has mal-rotated and it had resulted in a right occipito-transverse position. Okay. So what is that condition called? It is called as a deep transverse arrest. So that is why even after 2 hours, in spite of having adequate uterine contraction, the head is not coming below station 0. Okay. When there is a deep transverse arrest, what is the immediate next step? Deep transverse arrest, it's not going to come past the right occipito-transverse position. Already the baby has developed caput, already the baby is having molding. So there is significant amount of fetal distress for you to proceed with the lower segment cesarean section. So what is the treatment for deep transverse arrest? Lower segment cesarean section. The sagittal suture will be in either the right or the left occipito-transverse position. A primigravida presented to the labor room at 40 weeks of gestation with lower abdominal pain. She has been in labor for 3 hours. Which of the following will determine if she is in active labor? Okay, this is a question where you have to rule out only. Fetal head is 5 by 5 palpable on abdominal examination. If she is in active labor, will it be 5 by 5 palpable? No. So that is wrong. 2 contractions lasting for 10 seconds in 10 minutes. Is it active labor? No. In a 10-minute interval, she should have at least 3 to 4 contractions, each lasting for 45 seconds. That is what you call it as adequate contractions. 3 to 4 contractions in 10 minutes, each lasting for 45 seconds. But here she's had only 2 contractions lasting for 10 seconds. So that also can be ruled out. More than 5 centimeter cervical dilatation with complete effacement. Yes, that is active labor. Any cervical dilatation more than or equal to 4 centimeter you call as active labor. So that is the answer. Rupture of membranes. Rupture of membranes, it's indicating that your labor is going to begin. It's not a definitive sign that the patient is in active labor. Only after rupture of membranes, patient will progress into active labor. So that's an indicator that she is going to go into labor. So that is also not the answer. So the answer will be more than 5 centimeter cervical dilatation with complete effacement. Identify the blue colored area in the image below. Okay. Before that, we'll look into the different areas of the pelvis and then we'll come to that question. Okay. So as we all know, maternal pelvis will have a pelvic inlet. There will be a plane of greatest pelvic dimension, plane of least pelvic dimension, and an obstetric outlet and an anatomical outlet. Okay. These are the different parts. So inlet, plane of greatest pelvic dimension, plane of least pelvic dimension. So inlet, as you all know, it is from the upper border of the pubic symphysis to the sacral promontory. That is your inlet. Okay. Plane of greatest pelvic dimension is from the mid border of the pubic symphysis to the junction between the second and third sacral vertebra. Okay. Middle of the posterior border of the pubic symphysis to the junction between second and third sacral vertebra is the plane of greatest pelvic dimension. Plane of least pelvic dimension is from the lower border of pubic symphysis to the junction between the fourth and fifth sacral vertebra. Okay, that is the plane of least pelvic dimension or the mid pelvic plane. Okay, obstetric outlet is the part of the outlet that is present below the least pelvic dimension and the part of the pelvis that is present between the plane of least pelvic dimension and the anatomical outlet is your obstetric outlet. Okay, I'll come to the boundaries of the anatomical outlet. So the part of the pelvis that is present between the plane of greatest pelvic dimension and the plane of least pelvic dimension is your mid pelvis. Okay, the part of the pelvis that is present between the plane of least pelvic dimension and the anatomical outlet is your obstetric outlet. Okay, so anatomical outlet, what are the boundaries of anatomical outlet? The boundaries of anatomical outlet will be pubic symphysis. So it's diamond shape. Okay, which means there should be 2 triangles. Okay, 2 triangles. So anteriorly here there is a pubic symphysis and this border is formed by the ischio-pubic rami. Okay, the pubic symphysis will form the apex of this triangle and ischio-pubic rami will form the lateral border On the other hand, for the posterior part, the tip of coccyx will form the apex of the triangle, and the lateral border is formed by the ischial tuberosities and the sacrotuberous ligament. Okay, ischial tuberosities and sacrotuberous ligament will form the lateral border, and there is a common base for both the triangles. The common base is formed by the line joining the two ischial tuberosities. Okay, line joining the two ischial tuberosities is the common border. So this is your anatomical outlet. So part of the pelvis that is present between the plane of least pelvic dimension and the anatomical outlet is called as obstetric outlet. So what is our diagram that is shown here? So it is from, what is this? Starting from the middle of the pubic symphysis to the junction between the second and third sacral vertebra. That is the plane of greatest pelvic dimension. So next, what is this? Starting from the lower quarter of pubic symphysis to the junction between fourth and fifth sacral vertebra. It is the plane of least pelvic dimension. So what is the part that is present between the two? This mid pelvis. So what is the answer? The answer will be mid pelvis. What will be the level of the uterus on the second day post-delivery? 2 finger breadths below the umbilicus, 1 finger breadth below the umbilicus, 3 finger breadths below the umbilicus, 4 finger breadths below the umbilicus. So immediately after delivery, the uterus is going to be approximately 5.5 inches above the pubic symphysis. Okay, every day from then on, it will come half inch below. Okay, so now they've asked second day post-delivery. Okay, so half inch, it's approximately 2 finger breadths. Okay, so half inch below the umbilicus will be on the second day post delivery, the uterus will be 2 finger breadths below the umbilicus. Okay, so this is a table that is showing how the uterus involutes after delivery. Okay, immediately following delivery, the uterus will correspond to 20 weeks gestational age. So where will it be? Around 5.5 inches above pubic symphysis. Okay, which means it's going to be lie just below the umbilicus. And what will be the weight? It will be 1 kg. At 48 hours is when your myometrial involution is going to start. Okay. At 1 week, there is rapid involution. So the size will reduce to half from 1 kg to 500 grams. In 2 weeks, it's going to become a pelvic organ and the weight will become 300 grams. 4 weeks is when clinically involution is complete. Okay, weight will become 100 grams. 6 to 8 weeks is when the uterus is going to return to the normal size, and 8 weeks is the time when sonographically involution is complete. When you look by clinical examination, it might appear as though the uterus has completely involuted by 4 weeks. But if you do a scan and see, by 8 weeks only, the complete involution occurs. Okay, what will be the weight at 6 to 8 weeks? It will return to its original weight, which will be 60 grams. Okay. A 40-year-old G2P1 woman with 18 weeks of amenorrhea comes with a dilated cervix. The cervical length is 15 millimeters. In spite of explaining the risks, she insisted on cerclage. Which of the following is a contraindication for cervical cerclage? Ruptured membranes, prolapse of membranes into the vagina, fetal fibronectin positive, advanced maternal age. Definitely advanced maternal age is not a contraindication. Fetal fibronectin positive, it is an early indicator that the woman is going to go into preterm labor. So you can do cerclage in that case also. Prolapse of membranes into the vagina is not a contraindication for cerclage. You can do cerclage, but it should be done carefully without rupturing the membrane. So what is the answer? Once the membranes are ruptured, it indicates she's going to go into labor. So there's no point doing the cervical cerclage. The contraindication will be ruptured membranes. Okay. So when do you diagnose a woman to have cervical incompetence? Cervical incompetence or cervical insufficiency is the most common cause of second trimester abortion. Okay. The second trimester abortion, what will it be? Is it going to be painless or painful? It will be a painless vaginal expulsion. Okay. Painless vaginal expulsion. So if the woman had a past history of preterm delivery that has happened in the second trimester because of cervical incompetence, you can go ahead with a cervical encerclage. So how do you diagnose? On perspiculum examination, there can be prolapse of the membranes into the vagina. And on transvaginal ultrasound, your cervical length will be less than 2.5 centimeter with funneling of membranes at the level of internal os. Okay. So when is cervical encerclage done? It is done at around 12 to 14 weeks. When is the stitch removed? It is removed at 37 weeks. Okay. It is removed at 37 weeks or at any time the woman is going into preterm labor. Okay. Anytime the woman is going into preterm labor, or if she's aborting, in that case, you have to remove the cervical stitch. Okay. So what are the two different cervical stitch that you know? One is McDonald. The other is Shirodkar. So what is used in McDonald? McDonald, you use something called as the purse string suture. So if this is the cervix, you take stitches like this. That is your purse string suture. What is Shirodkar? Shirodkar is where you use the Marceline tape. Okay. So what is our question? Contraindication for cervical cerclage when there is ruptured membrane or any form of preterm labor or abortion. In that case, you are not supposed to do a cervical cerclage. A primigravida presents in the emergency room in the early stages of labor with adequate uterine contractions. On pervaginal examination, a gynecoid pelvis is felt, the membranes are ruptured, and the vertex is felt in the right occipito-posterior position. How will you manage this patient? Okay. So, there is a primie who's come in the early stages of labor. She's having adequate uterine contractions. On examination, it's an adequate pelvis. It's a gynecoid pelvis. Membranes are ruptured, but the vertex is in the ROP, right occipito-posterior. It is not in the right occipito-anterior. How will you manage? So, what should you do? Should you immediately do a cesarean section because it's in the right occipito-posterior position? No. You can allow for a normal delivery given the conditions. She's already in good labor. She's having adequate uterine contractions. Her membranes have ruptured. She's having a normal gynecoid pelvis. Given all these criteria, you can allow for a normal vaginal delivery. Okay. There are complications that can occur. Okay. As I already told, if the right occipito-posterior position is not rotating properly, it can lead to something called as a deep transverse arrest, where it will get stuck in the occipito-transverse position. So in that case, you have to take her for a cesarean section. Or sometimes it can rotate posteriorly, leading to something called as a face pubis delivery. But there are chances it can rotate back to the occipito-anterior position. That is why we are allowing for a normal vaginal delivery, provided it is an adequate pelvis and uterine contractions are adequate, which they have given in the question. So you will go ahead with a normal vaginal delivery. A pregnant patient with a history of classical cesarean section in view of fetal growth retardation in the previous pregnancy presents to you. She is currently at 35 weeks of gestation with breech presentation. What is the next step in management? Cesarean section at 37 weeks, advise ultrasound and visit after 2 weeks, internal podalic version followed by vaginal delivery, external cephalic version at 36 weeks. So what have they given? They've done a classical cesarean section. What is classical cesarean section? They've done a midline vertical incision on the uterus. Okay. So classical cesarean section has been done. Okay. She's come to you now at 35 weeks with breech presentation. What will you do? Will you allow for a normal vaginal delivery if it was a previous classical cesarean section? No. It is going to increase the chance of uterine rupture. So classical cesarean section is a contraindication for VBAC or TOLAC. What is VBAC? Vaginal birth after cesarean section. What is TOLAC? Trial of labor after cesarean section. So what are the contraindications for VBAC or TOLAC if it was a previous classical C-section? Or if there were more than or equal to 2 previous lower segment cesarean sections. Or if there was a previous history of uterine rupture. Okay. Or previously, if it was done for a recurring indication like cephalopelvic disproportion. In all these cases, you should not allow for a VBAC or TOLAC. So here they have given you classical cesarean section. This time also she is breech presentation. Even if it was cephalic presentation also, previous classical cesarean section, what is the answer? It will be cesarean section at 37 weeks. You cannot allow for a normal vaginal delivery. But if the question was previous lower segment cesarean section, if she has come to you now at 35 weeks with breech presentation, what will you do? You can do an external cephalic version, and if the external cephalic version was successful and if it became cephalic, you can allow for a normal vaginal delivery. But otherwise, you have to take the consent of the patient, explain the risk, okay, and then only go ahead with an external cephalic version. If it was successful, you can allow for a normal vaginal delivery, provided it was a LSCS. But here it was a classical cesarean section. That is why we are doing a cesarean section at 37 weeks. A 24-year-old lactating female with an 18-month-old child comes with a history of irregular heavy bleeding, seeking contraceptive advice. What is the contraception of choice? Progestasert, copper T380A, Mala N, norethistron enanthate depot injection. What is progestasert? Progestasert is a progesterone-containing IUD that can be inserted for contraception, but it cannot be given in case of irregular heavy bleeding because that itself can cause menstrual irregularities. So you will not give when there is a AUV component associated. So progestasert is contraindicated. Second thing, copper T380A. Copper T380A, whenever, what did we read for the contraindications for copper T insertion? Bleeding, we will not give copper T. So that is again ruled out. Next thing is Mala N. Mala N can you give? Yes, Mala N can be given. What is Mala N? Mala N is combined oral contraception that contains around 20 to 30 milligrams of ethinyl estradiol and 0.15 mg of levonorgestrel. Okay, so can you give Mala N? Yeah, it can be given. Okay, but Mala N, why we are not giving immediately after delivery? Immediately after delivery, up to 6 weeks at least, you will not give combined oral contraceptive pills. Why? One thing, it's going to increase the risk of thromboembolism. Second thing, it can lead to lactational failure. But here, the baby is already 18 months old. It's not only going to depend on breast milk for its supplement, for its nutrition. It will have other supplement feeds also. So now at around 18 months, you can start the woman on combined oral contraceptive pills. Can you give norethistron enanthate depot injection? No. It will increase the chance of menstrual irregularities. Okay, so progesterone only pills and progesterone containing IUDs will further cause menstrual irregularities. That's why we are not giving them, with the exception of Mirena. Mirena can be given, but others we are just withholding. Okay, so Mala and combined oral contraceptive pill. One more clue that they have given is she is also having AUB. So contraceptive pills can also be used for regularization of the menstrual cycles. So that is why along with the contraceptive part, it has an additional benefit and you are giving that. A 25-year-old male patient is evaluated for primary infertility. Semen analysis shows azoospermia. A testicular biopsy is done and the image is shown below. The finding is consistent with Sertoli cell-only syndrome, testicular atrophy, benign testicular neoplasm, and orchitis. Okay, so this is one classical histology picture which is called Sertoli only cell syndrome. Okay, only Sertoli cells are present. Your germ cells will be absent. Okay, so the presence of only Sertoli cells is what is called as Sertoli only cell syndrome. So it is characterized by thickening of the basement membrane, presence of Sertoli cells, and the absence of germ cells. So they can present in males as infertility and azoospermia. Okay, so it's confirmed by testicular biopsy. It's not definitely not testicular atrophy where there will be thinning of basement membrane. It is not benign testicular neoplasm also, where you can see the increased proliferation, atypia and all that, which is not there. Not atypia alone, there can be other features of neoplasm also which is not present there. Your sex cord stromal tumors and all will have something called Reinke cells. So all these are not there. Orchitis is a form of inflammation. So you should have some form of leukocytic infiltration, which is again not there. So what is the diagnosis? Sertoli only cell syndrome. A 20-year-old woman presented at 7 weeks of gestation, unwilling to continue the pregnancy. What are the drugs used for medical termination of pregnancy in this patient? Misoprostol and medroxyprogesterone, misoprostol and mifepristone, mifepristone and methotrexate, mifepristone and medroxyprogesterone. So what's the answer? It's a very easy question. It's misoprostol and mifepristone. Okay, misoprostol and mifepristone is what is used for first trimester medical abortions. Okay, so how will you give? When a woman is asking for termination of pregnancy, how is it given? It's given as mifepristone 200 milligram oral, and the ideal interval between mifepristone and misoprostol should be around 24 hours. Okay, at least 24 to 48 hours. So when she comes to your OPD saying that she wants a termination of pregnancy, you can give her 200 milligram of mifepristone orally, and then you can call her after 24 to 48 hours later to the ward for admission. Okay, then after that you are going to give her pervaginal misoprostol. So the dose of pervaginal misoprostol will differ depending on the period of gestation. At 7 weeks of gestation, ideally you can give 800 micrograms of misoprostol every 12 hourly for 3 doses you can give. Okay, even after that also, if she's not passed the products, okay, or if the scan is showing retained products, then you can go ahead with the manual vacuum aspiration. MV surgical method can be done. Otherwise, you start with the medical management. So how do you give? 200 milligram of mifepristone. 24 hours later, vaginal misoprostol can be given for termination of pregnancy. Testosterone helps in the development of various organs in the fetus. Which of the following stimulates its production? It's a very straightforward question. HCG from the placenta is what is going to stimulate the production of testosterone. Yesterday we saw a table. If there is an undifferentiated gamete, okay, that depending on the SRY gene on the Y chromosome, it's going to differentiate into either a male gonad or a female gonad. Okay, so but for the initial stimulus for the testosterone to form, you need HCG from the placenta. That is the answer for this question. A partogram of a woman who is in labor is shown below. Oxytocin infusion is already given. How will you manage this condition? Forceps assisted delivery, vacuum assisted delivery, oxytocin infusion, or cesarean section. I don't know if you can clearly see the partogram. So as you can see, what and all are the components of the partogram? The upper part will have the fetal heart rate. Okay. Here you will have the station of the fetal head and the cervical dilatation. Two components are marked here. Okay. So the upper part here, this line that is going above is showing the cervical dilatation. The line that's going below is showing the station of the fetal head. This is showing the time, okay, when you are doing the pervaginal examination. This table is showing the uterine contraction. Okay, uterine contractions are monitored. The below will be the mother's vitals. Okay, her pulse rate, BP. Okay, then about her temperature, urine ketones, any urine albumin that you are measuring, all that can be documented below. Okay, so in this case, as you can see, with oxytocin infusion and with uterine contractions, you can see that her cervix is dilating, but the fetal head is not descending beyond a point. Okay, it's persistently at station 0. Okay, station 0, station 0, station 0, in spite of giving adequate oxytocin, in spite of having adequate uterine contractions. So what is this? Head is not descending in spite of having adequate uterine contractions, in spite of having adequate oxytocin infusion. It is cephalopelvic disproportion. So any form of cephalopelvic disproportion, the answer is going to be cesarean section. Okay, forceps assisted delivery cannot be done, vacuum assisted delivery cannot be done. There's no point of giving more oxytocin infusion. Already she's having adequate uterine contractions. You can see how it is marked here. Okay, so oxytocin infusion also there's no point giving. So answer will be cesarean section. For which of the following procedures in the given OT list can you preferably do a hysteroscopy? Tubal ligation, Asherman syndrome, endocervical polyp, and subserosal fibroid. So what is the answer? The answer will be Asherman's syndrome. What is Asherman syndrome? Asherman syndrome is a syndrome where there is excess intrauterine adhesions owing to previous multiple dilatation and curettage. That is leading to the formation of raw surfaces and increased intrauterine adhesions. So you can do hysteroscopy. So why is it hysteroscopy? Why is it not an endocervical polyp? For an endocervical polyp, you needn't do a hysteroscopic resection and all. You can do a local polypectomy itself with sponge holding forceps. So that will not, even if it's interior also, you can do a hysteroscopic polypectomy if it's an endometrial polyp that is sitting inside. For an endocervical polyp, you needn't do a hysteroscopic polypectomy because it's located on the exterior part. Okay. So Asherman syndrome, the gold standard will be hysteroscopy. Why is it the gold standard? Because you can use it for both diagnosis as well as treatment. Okay, so you can do a diagnosis at the same time you can do a hysteroscopic adhesiolysis. So it's both diagnostic and therapeutic in case of Asherman syndrome. So the answer will be Asherman syndrome. A primigravida presents to you with anemia early in her pregnancy. She is 7 weeks pregnant as seen on ultrasound. Her hemoglobin level is 9 grams per deciliter. When should the iron supplements be started for her? She is already diagnosed to have anemia. She is 7 weeks pregnant. When will you start hemoglobin in iron supplements in anemic patients? You start it at 8 to 10 weeks. Okay. If it is non-anemic mother, you can start it at 12 to 14 weeks. For the first 12 weeks, you can give folic acid, and from 12 weeks onwards, you can give the mother iron supplements. But she's already anemic. So you need it wait till 12 to 14 weeks. You can start at 8 to 10 weeks. So according to that anemia Mukbarat program, how do you give? You have to give 2 tablets, okay, of iron and folic acid. So each will contain 60 milligram of elemental iron and 500 micrograms of folic acid. Okay, so this is for the Treatment of anemia. But if you want to start it prophylactically for non-anemic females, you can start it at 12 to 14 weeks. A 50-year-old woman presents with foul-smelling bloody discharge per vagina that is mixed with mucus. On examination, a necrotizing growth is seen in the cervix with large parametrium involvement. What is the management for this patient? So to know that, we should know the FIGO staging for cervical cancer. Okay, so this is an image that is showing the FIGO staging. It's very easy to remember when you look like this. So when it is limited to the cervix, it will be stage 1. 2A is when it is limited to the upper 2/3 of the vagina. 2B is when it involves the parametrium. 3A is when it involves the lower 1/3 of the vagina. 3B is when it involves the pelvic side wall or the ureter. 3C is the involvement of lymph nodes. And 4A is the invasion of bladder or rectum. Stage 4B will be distant metastasis. So these are the different stages of cervical cancer. So any form of growth on the cervix that is less than or equal to 4 centimeter, you can go ahead with a surgery. Other than that, if the growth is more than 4 centimeter or any form which has spread beyond the uterus to the parametrium, lower third of the vagina, pelvic side walls, lymph nodes, distant metastasis, all these conditions, you have to give a concurrent chemo radiotherapy. Okay, so for this question, what was it? A necrotizing growth is seen in the cervix with large parametrium involvement. Parametrium involvement is stage 2B. So what will be the management? The answer will be chemo radiation. Okay. A woman is said to undergo a complete laparoscopic hysterectomy. She wants to know if there are any disadvantages to this procedure. What are the disadvantages of laparoscopic over open surgery? Okay, this is also a very straightforward question. Prolonged recovery time. Is there prolonged recovery time? No. Recovery time will be faster in laparoscopic surgery. Not knowing the extent of thermal burns. Yes. Laparoscopy, the most important complication is if there is a thermal burn at the site of a site of insertion or anywhere where you are using any form of cauterization, you will not know the extent to which the thermal burn has extended. Increased bleeding? No, it will be decreased bleeding. Increased pain? No, it will be decreased pain. So what will be the answer? Not knowing the extent of thermal burns. A woman with complaints of pain and swelling in the perineal area also has complaints of difficulty in walking and sitting. She gives history of multiple sexual partners. On examination, a tender swelling with redness on the labia is seen. What is the most likely diagnosis? Pain and swelling in the perineal area, tender swelling with redness on the labia. What is the answer? It is the Bartholin's abscess. Okay, so which is an abscess that is involving the Bartholin glands. Bartholin glands are the counterparts of the bulbourethral glands or Cowper's glands in females. Sorry, in males. Okay, in females it is Bartholin glands. In males it is the bulbourethral or the Cowper's glands. Okay, so when it is infected, it can lead to something called as a Bartholin cyst. The Bartholin cyst further on infection will lead to something called as a Bartholin abscess. This Bartholin abscess can present as pain, tender swelling, discharge, foul swelling, discharge. All these can be present. Okay, it can progress and it can lead to lead to difficulty in walking and sitting. So what will be the answer? Bartholin abscess. What is the treatment for Bartholin abscess? Either you can do an incision and drainage or you can do a marsupialization for treatment of Bartholin abscess. A 23-year-old woman accompanied by her mother-in-law comes to the infertility clinic. She has been having regular intercourse for the past 6 months but is not able to conceive. What is the next best step? Semen analysis for husband. Reassure and review the couple after 6 months. Hysterolaparoscopy. Diagnostic hysteroscopy. What is the answer? What is the definition of primary infertility? Inability to conceive after unprotected sexual intercourse for a period of 1 year. But now it's only 6 months. So you can ask her to come after 6 months. Even after 6 months, if she's not conceived, then you can go ahead with the evaluation. Okay. In that case, you can do a hysterosalpingogram, hysterolaparoscopy, diagnostic hysteroscopy. All that will come in that place. Now you can just reassure her and call her after 6 months. Okay. A 28-year-old woman with a history of multiple sexual partners presents with lower abdominal pain for 1 month. She experiences minimal discharge and complains of intermenstrual bleeding. What is the most likely cause? The most likely cause: herpes simplex, genital tuberculosis, candida, Neisseria gonorrhea. What is the answer? The answer, before that we'll roll out. How does herpes simplex present? We all know herpes simplex will present as multiple grouped vesicles on a erythematous base. So here they've not explained anything about vesicular lesion. So herpes simplex is ruled out. Genital tuberculosis will present with lower abdominal pain, but there is nothing mentioned about the constitutional symptoms. What are the constitutional symptoms? Fever, weight loss. Okay, all that is not mentioned here. So genital tuberculosis is also ruled out. Candida is not going to cause abdominal pain and all. They will explain. They'll tell you about cardiovite discharge. Also, Candida is not sexually transmitted. So there is no point of giving the history of multiple sexual partners history there. So Candida is also ruled out. So what is the answer? Neisseria gonorrhea, that is causing the pelvic inflammatory disease. That is why the woman has presented with lower abdominal pain. Okay, so Neisseria gonorrhea is a form of genital tract infection that can lead to pelvic inflammatory disease. Initially, it will present as cervicitis, dysuria, abnormal vaginal discharge. Then it can progress as an ascending infection, leading to pelvic inflammatory disease. Okay, then it can lead to bloodstream infections also. So Neisseria gonorrhea is the answer for this. Most likely cause of the abdominal pain and minimal discharge in this condition is Neisseria gonorrhea. A 27-year-old pregnant G3P2L2 woman presents to you at 36 plus 6 weeks. Ultrasound is done and shows the fetus is in a transverse lie. The liga is adequate and the placenta is normal and she has no risk factors. Both her previous deliveries were normal vaginal deliveries. How will you manage this patient? Okay, so what have they given? This is her third pregnancy. Okay, she's come to you at 36 plus 6 weeks of gestation. You have done a scan. Fetus is in a transverse position. It is not cephalic. Okay. Then what have you checked? The liga is adequate. Placenta is normal. Upper segment. She has no other medical or surgical risk factors. Both her previous 2 deliveries were normal vaginal deliveries. So what will you do? The transverse lie. So she has no risk factors also. Liga is adequate. What can you do? You can do a external cephalic version at 37 weeks. Okay. So external cephalic version is a procedure where you're going to manually bring the head of the baby to the lower segment. Okay, changing the transverse lie to a cephalic presentation. Okay, external cephalic version has its own side effects also, has its own adverse events also. So like fetal distress, rupture of membrane, preterm labor. Okay, all these can occur. So when you are doing external cephalic version, you will explain all the risk factors to the mother, get an informed consent from her and the guardian, and then go ahead with an external cephalic version. Okay, so before you do an external cephalic version, you should make sure the baby is of adequate weight, liquor is normal. Okay, placenta is upper segment. She has no other medical or obstetric risk factors. In that conditions, you can go ahead with an external cephalic version. Okay, if she has some pregnancy-induced hypertension, GDM, placenta previa, okay, previously she had cesarean section. In all these cases, oligohydramnios, fetal growth restriction, in all these cases, there's no point doing an external cephalic version. Then you can slowly wait 37 weeks, you can do a elective cesarean section. Okay, so here they've given you no risk factors, liquor is adequate, placenta is normal. That is why you're going ahead with the external cephalic version. Okay, that is done at 37 weeks. A 24-year-old woman who was being treated for infertility with human menopausal gonadotropin came with complaints of sudden abdominal pain, nausea, vomiting, and breathlessness. The finding of the ultrasound is shown below. What is the most likely diagnosis? So what is she? She's on treatment for infertility with human menopausal gonadotropin, sudden onset abdominal pain, nausea, vomiting. What is the diagnosis? This ultrasound picture, it's classical of ovarian hyperstimulation syndrome. Okay, it might look similar to your polycystic ovarian syndrome, but they've classically given you treatment for infertility with human menopausal gonadotropin and all that. So in that case, they are more prone to develop ovarian hyperstimulation syndrome. Second thing, they've not mentioned anything about PCOS, any irregular menstrual cycles, hirsutism, acne, nothing about that history is mentioned. Okay, so basically there is increased vascular permeability that will cause the ovarian follicles to be distended with fluid. Okay, that is ovarian hyperstimulation syndrome. So how can you prevent or how can you overcome this ovarian hyperstimulation syndrome? So you can either reduce the dosage of FSH, okay, while doing the ovarian hyperstimulation procedure, okay, or you can replace the FSH with HCG when it is in the last week of ovarian hyperstimulation. In that case, you can avoid this ovarian hyperstimulation syndrome. Okay, it's not theca lutensis, it's not granulosa cell tumor also. The answer will be ovarian hyperstimulation syndrome. A 54-year-old woman was diagnosed with advanced cervical cancer. She has a 14-year-old daughter. What advice would you give her daughter? Advise HPV vaccine, screen for BRCA mutation, screen for PTEN mutation, perform cervical biopsy. 14-year-old daughter, what can you tell? You can advise for a HPV vaccination. So what are the 3 different HPV vaccines that we know of? Cervarix, Gardasil, and Gardasil 9. Okay. So this is an important table that's showing the differences between Cervarix, Gardasil, and Gardasil 9. So Cervarix is bivalent, Gardasil is quadrivalent, and Gardasil 9 is non-avalent. Cervarix will act against subtypes 16 and 18. Gardasil will provide protection against types 6, 11, 16, and 18, all the high-risk types. Gardasil 9, along with 6, 11, 16, and 18, is going to include the low-risk types also, which is 31, 33, 35, 45, 52, and 58. So according to the subtypes only, it's going to protect against the corresponding diseases also. So 16 and 18, it's going to protect against cervical intraepithelial neoplasia and carcinoma of the cervix. 6, 11, 16, and 18, 6 and 11, it's going to protect against anogenital warts, and 16 and 18, it's going to protect against cervical intraepithelial neoplasia and cancer cervix. Okay, here in addition to that, it's going to protect against vulval and vaginal intraepithelial neoplasia also. What is the dose? The dose is 0.5 ml intramuscularly in all the three. What is the administration schedule by which you can give? 0, 1, and 7 months in case of Cervarix, whereas Gardasil and Gardasil 9 can be given at 0, 2, and 6 months. All three can be given in both females and males. Okay, both genders it can be given. What is the ideal age? According to the CDC, the ideal age for administration of all cervical cancer vaccines will be 11 to 12 years. Whereas Gardasil 9, actual FDA approval is given for 9 to 15 years. But there is an AICP age recommendation. If they are previously unimmunized women, you can give up to 26 years of age also. 13 to 26 years also it can be given. Okay, this is a very important table from which lot of questions can be asked. Okay. So coming to the last question of our session, a woman presents to you at 36 weeks of gestation with complaints of feeling lightheadedness and dizziness when she lies on her back. She says she feels all right if she lies on her side or when she walks. What is the most likely reason behind this? Increased intracranial pressure, IV compression, heavy meals, or excessive venous pooling at the feet? What is the answer? The answer is IVC, compression by the gravid uterus. So when the woman is lying supine, what happens? The gravid uterus is going to compress the IVC. That will lead to a decreased cardiac output, especially to your brain. That will present as lightheadedness and dizziness. Increased intracranial pressure can also present with lightheadedness and dizziness, but it will have other visual changes also. Okay, visual changes in the form of papilledema, blurring of vision, diplopia, all that will also be present. Headache. But here they haven't mentioned anything about that. Heavy meals, they'll more commonly present like an epigastric pain type, epigastric burning sensation, regurgitation, all that will be there. Excessive venous pooling at the feet is what is going to present as your dependent edema. So it is not that also. So what is the answer? The answer is IVC compression. So that is why when you are advising pregnant women for rest, you should advise them to lie on the left lateral side and they should never lie supine. Why? Because it causes IVC compression. What is it called? Supine hypotension syndrome. Okay, so that's it. I hope the session was of some help for all of you. All the best for your NEET PG 2024 exams. Prepare well. These are all the high yield topics that we've discussed in OG. All the best and prepare well. Thank you.
Thank you so much, ma'am, for your effort and dedication. We have successfully completed the NEET PG Rapid Revision for General Medicine and OBG in 3 days. And we are also planning for the Ortho Rapid Revision in the upcoming week. Thank you so much, ma'am.
Thank you.
Hoping to meet you soon in the further
Thank
session.
you.